Okay, everybody got a whistle? Good afternoon, everybody. We're going to get started. If y'all want to sit down, we're going to get started. Okay. All right, good afternoon. Today is February 21st, 2024, and it is 4:01. As a quorum of the board is in attendance, I would like to call to order the meeting of the Central Health Board of Managers. So, managers, today we're going to take the meetings out of the normal order this afternoon to accept some input from our Central Health staff and also to hear from some very special guests today. So we'll receive public communication for the Budget and Finance Executive Committee and Board of Managers meetings before we recess the Board of Managers meetings and convene the Budget and Finance Committee meeting. So first we're going to start with public communication. So today is a special day for us. We're going to start to hear from some folks that we may have heard some from to some extent in the past, but we want to do this. We want to be sure we put this in place on a regular basis. So on behalf of the Board of Managers and staff, I want to share with the public that Central Health will begin an ongoing series of presentations during public communications that we're calling Mission Moments. During these brief presentations, staff, patients, or community members will share with us stories of how our mission is connecting people to healthcare and health coverage and going from an opportunity to live healthier as Central Health builds a better healthcare system for Travis County. This is a chance for us as board members to hear from individuals who are impacted directly by our services and to hear from people who are providing these services. So, too often there's a lot of, our role is to help guide policy, and a lot of times we don't get to hear directly on what's happening with folks. And so this is a huge opportunity for us, and we want to start that this time, and then we want to hear from everyone, from the public as well as from our Board of Managers, how this is working. And so we'll get to that in a minute. I want to thank Dr. Lee and our staff for pulling this together so quickly so we could start it at this meeting. So another thing that I mentioned that's very special for this particular meeting is February is Black History Month. And we want to open our public communications session today by making space to honor the contributions of African Americans and African American-led organizations to the Austin community. You will also hear about some special Black History Month activities led by the Central Health Diversity, Equity, Inclusion, and Belonging Council, and content produced by the Central Health Communications team celebrating Black History Month. Moving forward, we want to begin to recognize all United States History and Heritage Months. We want to recognize those publicly through our board meeting, in addition to what we have done traditionally in reaching out to the community. So we're starting this month, and we will do this every month this year. To recognize the importance of history and heritage. I want to thank Manager Jones for helping us, helping the staff put this together for today and for reaching out to our special guest today. So we're going to start with our first special guest, who is Larry Wallace Jr. If you want to come up and introduce yourself. Thank you so much for being here today.
Chairperson, board members, we appreciate the opportunity to be able to show you a video of last year, the impact that we've been able to have in the community, especially with your all support, and a few more remarks right after this. But I also want to acknowledge our founder and executive director, Larry Wallace Sr. is here as well.
Can you, for the public, just tell us all the group you're with? We know you, but the public may not.
Absolutely. So we're the Black Men's Health Clinic, partnered with you all here at Central Health, Community Care, Integral Care, Lone Star Circle Care, and so forth. And the video that we'll play will definitely go into more about what our model is and how we're approaching and engaging the community for greater equity and greater trust in the healthcare system.
Okay, thank you. Are we ready with it? Shannon, would you like to say something, Manager Jones?
Yeah, I would like the founder to come forth. I think he should be up front. So if he would come forward, Mr. Wallace.
It starts again. It ends and starts. It ends and starts again with the relationship. Why do we have to do what we do? And the reason we have to do what we do is because we understand the issues and the barriers that Black men and all men of color really face.
Usually, you don't see things that are focused on our well-being, right? This is focusing on our well-being holistically.
We're meeting people where they're at, and then also it's not hard to meet people when you already are part of the conversation, when you're a part of the culture. So that alone helps kind of bridge that gap between the fear and the mistrust in medicine, and then also actually having people say, oh, these experiences can be good, they can be enjoyable, they can be informative, and they can be non-judgmental.
Even though, the Black Men's Health Clinic sees everyone, right? But its focus is target population on Black men who need this kind of relief.
We try to remove all the barriers that they face to make sure that they can be in a safe place, a place where they can be restored. It's a place that gives hope and safety. Our tagline is, care you can trust.
The MAP program is Travis County's indigent care program. It's a critically important program. It's one for which taxpayers here in Travis County decided they were going to increase their property taxes to ensure folks who otherwise might not be able to access care of their neighbors could gain access to services. We know Austin is become less affordable over the last several years. And yes, they may have insurance, but they're not able to afford the co-payments because the cost of living is so high.
Just understanding that when you're dealing with a certain population of under-resourced or maybe homeless or unhoused individuals, they have a lot of more barriers than your average person. Imagine sleeping outside in a tent and waking up trying to get to a doctor's appointment. So you have transportation barriers, you have mental barriers, you have long-term substance abuse where these individuals are trapped in this lifestyle and this environment, and they can't even get to these appointments.
We go to where men work, live, and play. We don't set up a clinic and say, come to us, but we go to you. And we do that through basketball league sponsorships, barbershop. We don't just bring you into our space and wish you well. We walk this journey with you for life.
I think that's what's probably most unique is I've had folks say, why wouldn't you just do this yourself? Why wouldn't you just directly employ the outreach staff? I think we gain credibility through the credibility that Black Men's Health Clinic has.
Let me just express my appreciation for all that have supported this vision. It was out of the box. It was something that others have not done before. Everything we are doing and have done is for others. 35 years in healthcare administration, this clinic, this project that we brought together means more to me than anything I've done.
And with that that being said, hopefully we can be able to come back before you all and be able to speak on a new partnership with the Austin Travis County Sobering Center, as well as what we're doing with the funds in a new collaboration with Integral Care. Thank you.
All right, thank you guys so much for being here. I think our next guest is Michael Lofton. Michael, if you want to introduce yourself and...
Well, good afternoon. I'm Michael Lofton. I am the founder and executive director for the African American Youth Harvest Foundation. We're located in the same building with our partners over there. But I'm happy to just start out saying welcome you, Mr. Lee, to the team here. Been knowing Mrs. Kitchen for quite some time, and of course, Mr. Jones. But I'll just start out and say, and I'll try and get through this here real quick to be in a timely manner. The African American Youth Harvest Foundation, I feel we have a state-of-the-art full set of wraparound resources at our clinic. I will start out by wanting to invite you all to come out and take a tour, because I could talk for days and still do the center injustice. For starters, I'm happy to say one of our newest programs that we have brought on is the Trauma Recovery Center, which is the first in the state of Texas. I have provided you all with the data for the first 3 months. We launched this on November the 1st. We are working off of a national model, which is out of San Francisco. I'm happy to say, and on that, each one of you all should have this here. It's also, there's a cover letter from the state agency speaking to the fact of the Harvest Foundation, the Trauma Recovery Center needing more resources. And the reason I say that, our annual goal, we have surpassed our annual goal in the first 3 months. And so you have the data there, take a look. I am so happy to say that the community is coming out. There is a grave need for mental health and substance use. But aside from that, we have a number of other resources in the building that's provided by the Harvest Foundation. And I'll start out with STEM and technology. We have Austin Community College in there. You know, of course, the Black Men's Health Clinic. But we do everything. We have a food pantry. We have, what is that? I'm drawing a blank. Take a look at programs for senior citizens. We have Saffron Trust. We have City of Austin Satellite HR in the building as well. And then we have every Tuesday night, we have 125, 150 kids and parents there coming in for whether it be mental health, just all sorts of programming for kids, STEM, technology, the whole 9 yards. And so I would like for you all to come out, because one of the things that makes our model unique is the fact that we have over 25 to 30 African American independent nonprofits in the building. So when you walk through, I'm not here today to just speak to the Harvest Foundation, but to come through and take a look at all of the programming and resources that we have. We're even opening up in Manor. We have programming in the schools. We are bringing horse therapy to our program. We have land in Manor, and we've already built out the stables. So there's a lot of things and information that I think you all would really want to know. So just come out and visit and talk to our therapists, talk to our counselors, because at the end of the day, we need you by a long shot. And we've already surpassed our goal, so we're looking at how do we continue. I will say this here, within the next couple of months, we've already been told that the White House wants to come out and review what we're doing. We'd like to be able to say that you all are a partner with us. So without me going through the whole booklet, the booklet that I have here, these are all of the nonprofits that's in the facility with us, attorneys, you name it, we have it there. Martin Luther King stated this here, and then I'll end. He stated this when I had him here, Martin Luther King III. He was my guest speaker in October. He said, when I take a look at my dad's dream and his model on the beloved community, he spoke of all of the resources and equity and the inequities in resources. He said, when I walk through here, I see every one of those resources that he spoke of this here in this here one building. And he said it needs to be replicated. It's a revolutionary model. And if I was to leave one thing on the table, and that is we want to be able to buy this building and leave it to the community, because he would like to have a part of this building to be, a part of the King Center, a part of the beloved community. And so how do we take a model such as this and leave it to the community? And so the owner does want to sell us the building, so I would invite y'all to come out and take a look and let's discuss it. Thank you very much.
Thank you for being here. Appreciate hearing from you.
Thank you.
Next, I think who is next for us? Okay, would you do that then?
Chair Kitchen, can you hear me?
Yes.
Okay, perfect. Do you want me to read off the public communication?
No, I want you to tell us who is next, which I think is that Ted?
Yes,
Is our
next up we
staff?
have Imelda Majalca with the DEI Council.
Okay. Thank you. Come on up.
Good evening. My name is Imelda Majalca, and I'm the Diversity, Equity, and Inclusion Specialist here at Central Health. And I am here to share with you all how we have celebrated Black History Month. So the theme for this year's Black History Month is African Americans and the arts and how they have influenced art and all aspects of our society. So we have connected arts with health, right, especially mental health. A lot of our employees have shared with us Black artists, writers who have impacted their lives. They've shared books with us, titles, experiences, and all of that has been posted on our SharePoint. We have also asked them to bring their own arts, and this is an example of one. And we will be having an art display at the airport location starting tomorrow. And it will be there, these pieces will be there, plus other pieces, all throughout the week until February 29th.
That's great. Thank you.
Thank you.
Where in the airport is that?
Oh, it'll be in the main hall.
Okay. Okay, great.
So we'd love to see you all there.
Thank you.
Thank you, Imelda. Up next, we have Anastasia Sims with Central Health's Communications Department.
Hi, so I'm Anastasia Sims, the content manager here. So as we commemorate Black History Month and celebrate, it's essential that we reflect on the richness of the culture and our profound impact on society. When I say our, Black people's. Today, I want to highlight a video that we did featuring our employees that beautifully highlight the intersection of food and culture. In addition to this video, later in the month, we will be releasing another video as a part of our Good Bite series with our Director of Education, Leslie Godarzi. And so in that series, we did 3 recipes that are unique to the to the African American society, and we're putting a healthy twist on them. So look out for that video later this month. Go ahead, Edwin.
When I think about Black History Month and food, I think about soul food. I think about the seasoning. I think about the fellowship. I think about families getting together and taking the time to prepare good, wholesome family meals.
What comes to mind for me is going back to those childhood meals that harken good memories. So candied yams, pork chops, smothered turkey necks, fried catfish, black eyed peas, macaroni and cheese. These are all staples, not only during the holiday season, but on special occasions, Sunday dinner. Those are things that speak not only to my upbringing, but also my childhood as well. So it is that I definitely hearken to whenever I'm down, and I look for ways to implement them into my day-to-day dietary meals, but in a healthier fashion.
So when I think of Black history, the food that comes to mind is seafood from Baltimore, Maryland.
So when I think about Black history, food, and everything involved with it, one of my favorite dishes, or one of the things that I've grown to love is fried chicken. Of course, grandma's always making, that was one of my first Sunday meals. Of course, she would hit it with the mac and cheese and the candy yams.
I think about my grandfather and my grandmother. They lived in a home off of one income. They had a fig tree. They used their vegetables. He had pigs and cows, and he had chickens, and how everything was grown on the property to prepare meals for the family, and how we sat together as a family. And they also brought property, which was a farm later for them to retire at, and they only did that on one income. My grandmother never worked, but we never missed a meal, and it was always plentiful.
Comes to mind when it comes to food, soul food. My mom was the one that taught me a little bit about it and taught me how to cook it, taught me how what it was. It reminds me of, I love her greens, black-eyed peas, cornbread.
Thank you
That's
very
great.
much.
You're making us hungry.
I think you're next, Edwin.
Good idea.
Thank you, Anastasia. Up next, we have Edwin Evans with the Central Health Communications Department.
Greetings. So I'm Edwin Evans. I'm the photo and video content specialist here at Central Health. So this month I had the opportunity to create 2 impactful videos. These videos are in celebration of the Black History Month for us. So the first video you'll see features our new president and CEO, Dr. Lee. He did a great job on this video. It was very informative and gave a great historical sense of things that have been contributed from Black African Americans. The second video is from our own board member, Mr. Shannon Jones. He also did a great job, very impactful and thoughtful on just some historical facts and things. So I hope you all enjoy these videos.
As we honor Black History Month, it's a perfect time for us to reflect on the rich tapestry that is African American heritage and the many profound contributions to medicine made by members of the African American community. Throughout history, African American men and women have played pivotal roles in advancing medical science, promoting health equity, and advocating for marginalized populations. From trailblazers like Dr. James McCune Smith, who shattered barriers as the first African American in the United States to earn a medical degree, to the visionary Dr. Daniel H. Williams, founder of the first African American hospital. And let's not forget the pioneering researchers such as Dr. Myra A. Logan, the first woman to perform heart surgery, renowned for her groundbreaking methods in detecting and treating breast cancer. As we celebrate these achievements and milestones of Black history, we must confront the harsh realities of systemic challenges and injustices that persist, particularly in healthcare. Historically, Black Americans have faced discrimination and unequal treatment when seeking medical care, contributing to pervasive health disparities and higher rates of chronic illnesses in the African American community. By acknowledging the historical injustices and systemic racism entrenched in healthcare, even here in Travis County, we can begin to address these issues and strive towards building a more equitable and inclusive healthcare system. Together, let's honor Black History Month by not only celebrating the past, but also by rededicating ourselves to the pursuit of a brighter, more equitable future for all.
As we celebrate Black History Month, we reflect not only on the rich tapestry of African American heritage, but also on the ongoing journey towards health equity and access here in Travis County. Over the years, Central Health and other public health agencies have embarked on numerous initiatives to uplift and empower the African American community. From the pioneering outreach services targeting colorectal screenings to the establishment of public health clinics in underserved areas of our community. Our commitment to improving access to quality health care has remained unwavering. We have engaged with faith-based groups recognizing the pivotal role they play in fostering community wellness. Through partnerships and collaboration, we have amplified our efforts reaching those who might otherwise be left behind. In recent years, milestones such as the opening of the Black Men's Health Clinic and the Hornsby Bend Health Clinic stands as testament to our commitment and dedication to addressing the specific needs of African American communities. These clinics serve as a beacon of hope and healing, offering vital services and support to those who need it most. Central Health launched its Health Equity Plan in 2022. Looking ahead, our vision remains bold and ambitious. With plans underway for the opening of the Del Valley and Colony Park Health Centers and our specialty clinic at Rosewood, Zaragoza, we are laying the groundwork for a future where equitable health care is not just a dream, but a reality for all. As we celebrate the legacy of African Americans and our contributions to the collective story, let us also recommit ourselves to the work that lies ahead. Together, we can build a healthier, more inclusive future for generations to come.
Thank you. Those were nicely done. Very nicely
Thank you. I
done.
hope y'all enjoyed those.
Thank you, Edwin. And lastly, we have Aida Cerda Praja with the outreach team at Central Health.
My name is Aida Cerda Praja, and I'm the Community Outreach Supervisor for Central Health. I'm here to share with you my Central Health mission moment. Oh, do I have to start over? Okay. We community health workers are always on the job. Even when we're not on the clock, we're working. I belong to the St. Vincent de Paul Society at my church. People reach out to us to get help with rent, utilities, food, and other needs. Recently, we did a home visit with a gentleman who had fled Venezuela due to political persecution. At home visits, I always ask if the person has health coverage. This gentleman did not. Not only that, but he was also an amputee. He and some friends traveled to the U.S. by way of Mexico, and when they were in Mexico, they were robbed by the cartels. There was a struggle, and this person was pushed onto the railroad tracks. He was not able to get away fast enough, and he was run over by the train and lost his foot. The injury got infected, and doctors amputated his leg just below the knee. Even then, after he recovered, he was able to make it to Austin, where I met him. In fact, that's him right there on the video. We helped him with an online map application and even got him an enhanced library card, which he can use as ID. We were able to get him some food from a food pantry, a space heater, bus passes, and a hands-free crutch and insulated backpack that were donated by a generous community member. We always advise our new MAP patients to make that first appointment to establish care. He was having trouble getting an appointment, so I referred him to the Black Men's Health Clinic, where he was able to get an appointment within 2 weeks. He established care and got a referral to the Hanger Clinic, where he will be fitted with a prosthetic leg. He will soon be able to walk without assistance, which will not only improve his quality of life, but it will open up job opportunities. This was all due to having MAP. He is so grateful for all that Central Health and MAP have done for him in a very short amount of time. And he signed up for our new accelerated Community Health Champions class in the Runberg area, and he can't wait to be an ambassador for health in our community. This is my mission moment, and it's why I'm so passionate about the work I do, even when I'm not on the job.
Thank you for your service. Thank you so much for your service.
That's him right there with the hands-free crutch that was donated, and the backpack where he walks to food pantries and to get food. So now he can bring back cold foods and whatnot. It's awesome.
Thank you so much.
Thank you.
Really appreciate that.
And we thank the Black Men's Health Clinic for having provided an appointment for him so that he could access those resources. Thank you.
So thank you all for your presentations and comments, and thank you to the staff for pulling this together. And this mission moment that we had the opportunity to hear will be something that we continue at future board meetings. So the Board of Managers meeting will stand in recess and until the conclusion of the Budget and Finance and Executive Committee meetings.
I'll have a 5-minute break.
But you can go ahead and start. Slow it down.
Good afternoon, everyone. Today is February 21st, 2024, and it is 4:36 p.m. As a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Budget and Finance Committee. As a reminder, I don't believe we have any committee members maybe also participating by video conference, so the staff will be managing both video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. Members in community, it would behoove me if I did not take a minute to address the ongoing atrocity that is happening right now in Gaza. There's over 100 million individuals who do not have access to food, water, medical aid, or shelter, it's ongoing right now. As many of you know, I am Palestinian. I have family members there, and it's hitting home. And there are moments that I cannot wake up in the morning thinking of what's happening. Are they going to make it or not? But as a person who, while we're addressing health inequities and disparities, and as a public health person, I have the moral and ethical obligation to talk about the people, and I will. I just hope we all can come to a conclusion and for a ceasefire soon. And a ceasefire means a stop of killing of all innocent civilians and who've lost their lives, and about 70% are children. So, thank you for giving me the opportunity to speak. And now moving on to agenda item number 1. Approve the minutes of the January 17th, 2024 Budget and Finance Committee meeting. I move that the committee approve the minutes of the January 17th, 2024 Budget and Finance Committee meeting. Do I have a motion? Manager Brinson moves. Do I have a second? Manager Kitchen seconds. All in favor?
Aye.
Any abstaining? No. The motion passes. Thank you. Moving on to agenda item number 2, receive a presentation on the preliminary December 2023 financial statements for Central Health. Jeff Knodel and Patty Bethke will be presenting. Welcome. And I believe we have a handout, correct? So members, there's a handout as well in your packet if you want to follow through. Oh, this is for the, sorry, my apologies. This is for item number 4, but we will come back to it. Thank you.
Thank you. Apologies. Jeff Knodel, Chief Financial Officer, and Patty Bethke is with me. And we're going to do a quick, abbreviated presentation of our December 31st, 2023 financials. And next slide, next slide. Couple of highlights. We'll look at property tax collections. Our property tax revenue for December is $121 million, which is, excuse me, 37.6% of our adjusted tax levy, and that compares to $115 million or 40.1% of our adjusted tax levy as of December. So you may notice that it's slightly under from last year, but as of January, so we went and looked at January just to look, since that's when property taxes are due, and that amount has actually kind of flipped from a comparative standpoint. So as you look at, and we'll report January next meeting, but as we look at that, our percentage of collections compared to the tax levy is actually much higher than the prior period. So that's something that it's a metric we look at, but we also want to look at when the property taxes are due and just evaluate where we're at during that collection period. Healthcare delivery, Healthcare delivery is $40 million compared to $28 million last year. We also had in December, we had a $12 million payment to Sendero to maintain sufficient capital levels as required by the Texas Department of Insurance. And then last is our LPPF balance, and you'll see that that amount is approximately $85 million. So next slide. Excuse me. So this is our balance sheet, comparative balance sheet as of December 31st, 2023. And I'm just going to go through it quickly. Our total unrestricted current assets are almost $786 million. We mentioned in the highlights the LPPF balance, and you see underneath that the restricted LPPF cash and investment balance of $85 million. We also mentioned in the highlights the $12 million capital payment to Sendero, and so you see under right under the long-term assets, $83 million, which is the total paid-in capital to Sendero. But you see when you look at the prior year that there's a $12 million difference, and that reflects the $12 million payment that was made in December. Total assets at a little over $1.5 million, and again, that's a large number, and it's as we've talked about in our last year's reporting, we were required to implement some both capital lease and software subscription amounts that we report. Kind of think of it as a long-term grossed up period, and so that over time has really grossed up our balance sheet amounts. On our current liabilities, $230 million as of December. Part of that number, why that's again so large, is December or January 31st is when our property taxes are due, and so you see the offset of that receivable, the $200 million that we report in current liabilities. Restricted or non-current assets of $541 million. Our total liabilities are $772 million, and then net assets are a little bit over $800 million, and again, just liabilities and net assets are the same amount as our assets. Flipping over to our sources and uses as of December. Next slide, thank you. So again, we talked some about property tax revenue, and you can see that our property tax amount, as we highlighted, is right at almost $121 million, which is 39% of our budget. And then you see from a comparative standpoint, last year we were at almost $115 million. The other thing that I would point out is our investment in other revenue. We budgeted $7.5 million for that line item, and as we continue to see higher interest rate returns, we would expect to see substantial increases in that amount. Unfortunately, no one can predict interest rates, but just kind of where we're at and where we think we're heading, we will probably be substantially over budget on that line item, which is a good thing. So we're talking about being over budget on a revenue item, so more revenue than what we budgeted. So that's good. Remains to be seen how much. On uses of funds, our healthcare delivery program, again, right at almost $40 million. Our administrative program is at $5.3 million. And then you see a transfer to our emergency reserve fund of $8 million. Our total sources over uses, you see it's at $78.6 million. And again, this is, we're showing a larger positive number because we've collected a lot of property taxes at the beginning of the year, and that's normal for our cycle. And as we get closer to our year end, you'll see that number decrease. And then you see at the bottom, our reserve balances. Our emergency reserve is at $46.7 million. And then our budgeted amount for our contingency reserve is $377 million. And we'll be bringing back the fiscal year 23 year-to-date number next month as we wrap up our fiscal year 23 financial audit. So we'll supply that next meeting for next financial statement run. Next slide, just a little more detail. Next slide. On our healthcare delivery program, as we look at purchased healthcare services, year to date, we're at $23.2 million, which is substantially more than last year at this time. In December of 2023 of $16.4 million. Our direct services, as it relates to specialty care, so we're just bringing some of those services online. Just as a reminder, we began services at East in October, and then we executed a lease and began services at Capitol Plaza beginning in January. And so you see that that's starting to begin ramping up, and of course we'll see some substantial increases over the next several months, including Rosewood Zaragoza coming online later this year. I think that's from a highlight standpoint. Let's go to the next slide and just look at detail of our specialty care purchase services. You see, as of the end of the year, the end of December, we're at $3.7 million. And last year, we were at approximately $2.4 million. And again, a lot of the specialty care services are beginning to ramp up, and we would expect to see substantial increases throughout the year. So that concludes our abbreviated presentation. Be happy to answer any questions that the committee may have.
Appreciate it. I have a quick question on page 4 of your slides under assets. So just wanted, if you can just briefly touch base on 2 outliers. Now, the first one, the total restricted cash investment, if you can talk about that line item. And the second one, I think it's under debt services payable, and why they're different from the previous years. So, because they're significantly different. Thank you.
Sure. So total cash in investments consist of two line items, or 2 items. The first is the LPPF, the local I can't remember now what it is. Local provider participation fund. So that's where we act as the administrator, and the board sets a collection rate not to exceed 6%. Central Health, as the administrator, collects the dollars that are used for intergovernmental transfers for supplemental funding programs. And so that's just a balance at a point of time. And then our restricted for capital acquisition, that's just what's known as our capital reserve. So that's where we have our capital account for capital projects, for where we build for example, our facilities, our clinics. So we've issued that for that, and we have some cash funding in that account. And these are funds that are set aside for that. Secondly, on the debt service, was it the current liabilities? Was that, or was it the
Yeah.
long-term?
No,
Yeah,
it's,
so,
yes.
so both of those amounts are the short-term portion and the long-term portion. These equal the amount of basically for Central Health contractual obligations that have been issued or debt that's been issued by Central Health. And so the short-term portion is the amount of principal that's due within 12 months. We typically do an interest and a principal payment in March 1st. So that reflects the short-term portion, and then the long-term portion would be the remaining balance that we have left on our debt issuance.
Thank you, appreciate that. And I forgot to mention, Dr. Lee, this is your first board meeting, and this is your first meeting to our Budget and Finance. Welcome. Just want to recognize you.
Thank you, Chair Masaitif.
Thank you. Any questions from board members about this item? So I see none. Thank you so much,
Thank you very
appreciate it. And there are no action on this item. Now moving to item number 3, receive and discuss the quarterly financial and operational reports for community care health centers and Sendero health plans. Members, I am going to take the, first we're going to take the community care. Jason Fournier and Tara Trower will be presenting from community care, and that we'll have their presentation, Q&A, and then we'll go on to our next item. So just much easier than what we did previously where we went back and forth. Welcome. Thanks for being here.
Yeah, thanks so much, Manager Ram. Really appreciate the opportunity to be here this evening with the Board of Managers and the Budget and Finance Committee. And very pleased to provide an update in terms of our first quarter of operations at Community Care. Joining me this evening, I'm Jason Fournier. I'm the President and CEO for Community Care. And to my right is our Chief Strategy Officer, Tara Trower. Her and I will be tag teaming this presentation. I'll start and then she'll go ahead and then I'll come back. So the first quarter for us aligns with the same fiscal year that Central Health has. Our fiscal year begins October 1st. And so we're talking the time period October 1st through December 31st, and that's what we're reporting on. By way of background, though, one of the things that this time of year always presents to us in February is that annually, as a co-applicant with the grant for the health center program with Central Health, we submit to the federal government a report known as the Uniform Data System Report. It's also commonly referred to or affectionately referred to as the UDS report. And we highlighted in the report, and this is an annual report that every health center, there's almost 1,400 health centers across the country, serving about 15,000 communities with about 31.5 million individuals served across the network of health centers. So this is a robust report that is submitted to the federal government, includes financial information, service delivery, also cost information, quality of care indices, and Tara will speak more specifically to our progress on the quality front this year. But really wanted to highlight, if we could advance to the next slide, really want to highlight some of the things that we saw and observed year over year. So comparing 2023, and this is calendar year report, to 2022, we actually saw an increase in the number of unduplicated or unique patients served to the tune of about 4%. We increased to 134,180 unique lives cared for last year in 2023, comparative to 129,005 individuals the year before. So that's a 4% increase. Our patient population, next slide. Sorry, this is just an overview of our strategic plan. Our patient population continued to remain very diverse. What was most notable is 60.62% of our patients are best served in language other than English, which is the highest level ever that we've had within. Our number one language served was Spanish. Number two is English. Number three is Pushtu. Number 4 is, number 3 is Arabic. Number 4 is Pushtu. And number 5 is Vietnamese right now, just to give you a little bit of background there. Our overall patient population self-reported. Not every patient tells us their race or ethnicity, but over 87% of our patients self-report as belonging to a community of color. So African American, Latino, Asian American, Pacific Islander, et cetera, as it relates to their background. Additional to that, 98% of our patients report that they have incomes at or below 200% of the federal poverty. So we are definitely aligned with what the federal government is intending us to do collectively with our partners here at Central Health, is to get services to individuals who are lower income. For perspective, based on 2022 federal poverty tables, that's a little bit above $59,000 for a family of 4, just so you have perspective living here in Austin, which it was mentioned earlier this evening, is becoming less and less affordable, right? What's really notable is the level of uninsurance that we see. Average across the country, based on 2022 data, 24% of health center patients nationally are uninsured. When we take a look at ours, it jumped from 47.2% to 51.2%. We saw a significant increase in the level of uninsurance. No, please, previous slide. No, next slide. That's the healthcare for the homeless. I'm not looking at it, I'm just speaking to it. So when we take a look at, yes. So when you look at the top right, you can see 51.2% of our overall patients are uninsured. So we're upwards of 65,000 individuals plus now that are uninsured being served. Many of those individuals that are Travis County residents are actually reflective of low-income uninsured individuals, for which, of course, Central Health provides access through MAP Basic. About 43% of our adult patients and pediatric patients are covered through MAP Basic now. And we'll speak a little bit more to some of the shifting sand or transitions that have happened as a result of the end of the COVID-19 pandemic, and they were highlighted in the report for you as well. What's most notable is we saw a slight increase in our adult population, closer to 69% of all of our adults, and we served over 82,000 unique adults last year. Close to 69% were uninsured. Where we saw the most dramatic increase was in our kiddos. We went from 17.8% to 24.3%, representing a 36% increase in our pediatric population, now finding them at the end of 2023 uninsured compared to 2022. The question then is why is that? So as part of the COVID-19 pandemic, I'm sure you're probably fully aware, but there was continuous Medicaid benefits provided to individuals. And that not only impacted our pediatric population, they didn't have to re-enroll every 6 months like they do again now, as well as our prenatal population. They were continuously, so if we saw a woman who was pregnant back in July of 2020, she gained coverage all the way through May 9th of last year, 2023, underneath the pandemic. So she had continuous Medicaid coverage. After redetermination started following the end of the pandemic emergency, that coverage was lost. So the first individuals that we saw starting to lose coverage were women who were covered throughout the pandemic and now have become uninsured again. And so we, with our partners at Central Health, as well as Community Foundation, who's been contracted with some federal funds, and others are trying to make sure that folks are getting enrolled. The bandwidth to do that is not large enough for us to be able to meet everyone's needs. The other part is even for the redetermination for pediatric patients who would otherwise still and should be covered by Medicaid, there's a bottleneck. The state resources, as you've probably seen and heard in the media, are not actually meeting those needs. So a lot of demographics that we're showing up here. What's most notable on the right-hand side is just the level of service, though, provided to Travis County residents. I think you're fully aware that our service area extends beyond, as approved by the federal government, beyond the geographic boundaries of Travis County. It includes 5 zip codes in Bastrop County, some of which overlap with Travis County. Of course, the zip codes don't adhere to county lines, so we've got some that extend down into Caldwell as well as to Williamson, but we have a clinic both in Bastrop, up in Round Rock as well. Round Rock's a pediatric site, the Bastrop's a women's health site, which will be expanding into pediatrics. On the right-hand side, though, you can see for peds, a little bit over 81.1% of our 52,000 plus plus pediatric patients were Travis County residents. And then as we step up, 18 to 64, you see that jumps to almost 85%. And then we get to our older population, almost 88% of our older population. And that's a smaller cohort, but there's still thousands of patients in that older cohort. And that's actually the fastest on a percentage basis, not sheer number, percentage in growth overall in terms of patients. So you can see that overall, that 83.4% of our patients are actually Travis County residents. The other thing to note is we partner with the City of Austin through the Ryan White Transitional Grant Area, and we have a 10-county area, and then we also work with the Brazos Valley Council of Government for HIV/AIDS services and other services as well when we take a look at how extensive some aspects of our services are. Next slide, please. So the next one is really, you guys can take a look at this. I won't jump into it other than noting that we had a staggering increase in our Healthcare for the Homeless initiative. Part of this is going to be explained that in the previous year, we were fairly new in our implementation of EPIC, so we didn't fully capture all of our homeless status, but it doesn't explain this huge jump. That was about 400 patients more than the 2,920 reported in 2022. That number jumped to 4,765 last year. That is the highest number of homeless individuals we have served since Community Care absorbed the clinics from the City of Austin back in 2009 in partnership with Central Health. So a 62.2% increase in the homeless individuals. And as you know, based on local reports, media, the homeless population continues to grow in our area, unfortunately. Advance to the next slide. We're going to skip over the next one if we can go to. This one here is just so you have the data from last year, 2022, for comparison. So you've got that as well. So next slide, please. Appreciate that. So what have we seen in the first quarter? We're actually seeing, on a service delivery perspective, we're exceeding our budget expectations. And our budget expectations were above what we had done last year. So everything is pointing to probably closer to 138,000, 140,000 unique lives touched this year in terms of this the calendar year of 2024. When we take a look at it, the number of face-to-face encounters, and what's a face-to-face encounter is defined by the federal government. It's when we have a billable provider, a physician, dentist, psychiatrist, and others that are actually interacting face-to-face with a patient, but that can also include virtual. And we had a staggering 68,000, I've said staggering twice, I'll make sure I don't do that again, apologies. 68,203 unique patients. We were up by about 2,500 patients comparative to last year for the same time period. So we're actually going ahead and seeing that number increased by almost 6,000 patients in the first quarter. There's a couple of things that explain that. One of them is that last year we had struggles recruiting pediatric providers and some other type of providers, internal medicine, family medicine. Thanks to the enterprise HR human resources initiatives, we've narrowed that gap down. We've been able to successfully recruit through networks that we have and Central Hall has, so that's been narrowed. So a lot of very good things. We've also, one of the major things that our board at Community Care has charged us with is increasing access to care. And this year we've set a priority of increasing access to care for low-income Travis County residents through MAP and MAP Basics specifically, and trying to increase access that way. And so we're seeing that as we continue to move forward. You can see a lot of the breakout demographics. I'll go ahead and premise the 81.2% Travis County residents. It's closer to the 83. What we noted recently after this analysis was done is that when we geocode our patients' addresses, we've recognized that the systems that we're using to capture this information defaults to a county being presented to our staff as Bastrop or Travis. And unfortunately, they're defaulting to Bastrop when the person's actually Travis. Same thing with Williamson patients. They're defaulting to Travis instead of Williamson. So we're redoing and updating that. So just a little glitch in terms of our processes that were identified within the last couple of weeks. So it's closer to about 83 to 84% of all of our patients being Travis County. Next slide, and I'm going to hand it over to my colleague here.
Thank you so much, Jason, and thank you, Board of Managers, for having us here today. I'm going to talk a little bit about some of the specific initiatives Jason has done a great job going over the numbers around our growth. One of the things that we are measured also by the federal government are quality measures. And so as part of UDS, there are 16 measures that we track and report to our board every month, and there are a number of goals around each one of those. What you see here is sort of the breakout in terms of improvement. We did improve last year in 13 out of 16 of the UDS measures. The most significant improvements were in the dental sealant program, and then the measure related to adult BMI and follow-up, that improved by 12.7%. The previous dental sealants, we improved our performance on that by 26.5%. Other measures where improvement was pronounced but not as great had to do with our diabetic A1C measure, childhood immunizations, which I will say particularly our nursing and care management folks have put a lot of energy in making sure that coming out of COVID, our kiddos are up to date. I will say that the way that one is measured, if you're 1 day late, which parents care not quite as much about, we are considered delinquent. And so this is really notable progress on this particular measure. And same with depression remission at 12 months, that improved by 5.3%. The other 6 were less notable, but increases nonetheless. I will point out areas that we have identified as opportunity areas for next year is our child weight assessments and counseling, depression screening, and our colorectal cancer screening. And we've got action plans put together to make sure that workflows permit to make sure that we hit all of those marks and continue to improve the next year. Yeah.
Yeah, I'm not too bored to do it.
I was hearing somebody's background noise.
Yeah. I think it's gone now. All right, I will keep going. Next slide, please. So when you take a look, and I've talked with you before, some of the money that we received from both the state and federal government was continuing COVID vaccinations for folks, even though we're on, year 4, that really making sure that we reach some of those underserved communities that either had higher than vaccine hesitancy than other groups, or barriers to care, including transportation. The program both helped fulfill pop-up vaccinations within our clinical sites, as well as non-standard sites that we focused in the Eastern Crescent of Travis County. And so just wanted to share with you all some of the results in terms of total of individuals vaccinated for COVID through this program, 1,676. From talking with the teams that report to me, many of these were first-time vaccines. They were in the trenches, talking with folks, really trying to put them at ease, in addition to an advertising campaign program that we were able to put forward and really targeted zip codes with some of our highest needs areas that were most directly affected by the COVID pandemic. We did 187 events over the course of the 12 months. And you see here the zip codes that we targeted, which are also some of our highest needs population sites. And so this is just one example of some of the community work that we do that is open not just to our patient population, but for folks who are in need. We were able to use the new Hornsby Bend site for the month that we were still waiting for HRSA approval to do primary care as a vaccination site as well for both COVID and flu. Next slide. So we talked a little bit already about Medicaid and the teams that have been working very, very hard to get folks who are eligible to be on Medicaid back on Medicaid, and those who no longer have eligibility due to their status onto MAP or some other coverage if they are eligible for. And so just wanted to just bring your awareness. We did in addition to cold call outreach, we did a text messaging campaign, which netted us 260 some odd applications in the last 2 months of November, and I'm still waiting for the final tally of January. One of the things that I will say that we are seeing that as our patient population gets better educated on being hacked, that we are needing to be more creative in identifying ourselves as texting them because the links are not as effective as they once were. But we're still working on that. Next slide. So in addition to those texts, we also assisted with the application process. You see here that top bar, the 205, those are applications without an account. Those are new Medicaid applications that we were able to assist with. And then assisting patients with an account, those were those who were once qualified and either via redetermination or if we got them before they were dropped off, we helped them through the reapplication process. And then I mentioned cold calls. Jason referred to the partnership with Foundation Communities. We kind of split the difference, and Foundation Communities concentrated on our out of Travis County patient population, while Community Care really tried to work through the bolus of which was in Travis County. And so when you look at those direct contacts, we did cold call and outreach nearly 3,000 individuals over the past few months.
And quite a few of those individuals actually transition into Math Basic through these efforts, just for your awareness.
Yes. Next one.
So I've got this. Part of the report to the Budget and Finance Committee is to talk a little bit about finances beyond. What we're seeing is a fairly significant shift in our payer mix year over year as a result of Medicaid redetermination. We knew it was coming. We didn't expect that the state was going to struggle as much as it has. I mean, the rolls are going from roughly 5.2 million Texans, and it's going to level out. The thought is it's going to be close to 3 million. So it may actually be less than what we had prior to COVID. We were at 3.4 million, and there may be a ramp up. Some good news you may already be aware of is that the Centers for Medicare and Medicaid Services did go ahead and approve the 12-month postpartum continuation. That's effective March 1st. What's most interesting about that is there's some retroactivity. So if one of our women lost coverage in October, she won't gain coverage from November through the end of February, but they're supposed to re-up and be able to have her covered until at least next October, right? So whatever that cut date is. And then there's 12 months postpartum. So we're waiting on information about how do we support that re-enrollment of individuals who have lost their coverage through continuous Medicaid, and then that process moving forward. So we're monitoring this very closely. A lot of efforts around what we're doing. We're actually executing an agreement to bring in outside help to help with the Medicaid redetermination because that's a significant source of our funding. Many of our folks are transitioning to Travis County coverage into care programs through the medical access program, but we're also seeing some folks who are not, either because they can't timely get in for an eligibility visit, right? There's only so much bandwidth that we have. I know our partners at Central Health are similarly trying to get folks enrolled in MAP, but at the same time, we've got folks who then are qualifying for sliding fee scale or right now they're falling into a self-pay category based of their own choosing. And so we're trying to facilitate and enhance our systems to better support, but the bolus of folks coming through is greater than what the system really is capable of managing at this point in time. And so part of that's leveraging in technology. So in late January, we flipped on an online application for our sliding fee scale and other programs through Epic, through the use of MyChart, so advantaging that. Similar to Central Health, we've had an online application in place through RedCap, so that's where we first started in terms of accepting online applications. So we're trying to get the word out there that you can go ahead and do that, but there simply and surely is opportunity for us to enhance the experience for our patients and streamline that experience for community members at large so that they can connect with the resources they so need and deserve. When we take a look at our overall overall patients, you can take a look at the 68,203 really were drawn from 10 Travis County zip codes. So it's consistent within the past. These zip codes remain the highest needs within the community and represent 60% of our patients served through the first quarter. What you'll note at the bottom of this particular slide is that we are, for the first 3 months, experiencing an operational loss. So this is our revenues are less than our expenses. The good news is the expenses are higher because we're retaining more folks. We're also seeing increased spend relative to our employee participation and benefits. We have more folks participating in our collective health insurance program, including loved ones, than we've ever seen before. And that's from a percentage, not just a sheer number. And so there are cost implications, of course, for us as we're navigating that. Last year, we had an operating deficit as well of $270,000. We were able to overcome that throughout the remainder of the course of the year. This year is going to be more challenging just simply as we're moving down this path of less folks covered through Medicaid. The initiatives around that to stabilize that, but we've got other initiatives. One of the things that we have just launched as of January 1st is we're part of a accountable care organization REACH program at the national level in partnership with another entity here in town. And we've got twice as many lives in that Medicare Advantage ACO REACH program that we initially thought. So we're leveraging value-based care relationships in that. Next slide, please. You may have seen this in some news releases as well. Community care was recognized through the Austin American-Statesman as a top workplace in the last quarter. So we're very pleased. Of note, we were kidding around. We said we're number 11, right? And that's what we were. We were number 11 of the big businesses, right? Which I think, if I recall correctly, it was over 700 employees. Our peers at Sendero got the small business. We were number 11, but we were number 1 for nonprofits. So we were competing against, JP Morgan Chase, which I'm still trying to figure out where their headquarters are here. I know they've got banks all over the place, as well as Progressive and some other big for-profits, right? So we were the first number 1 nonprofit. So we'll say we're number 1 on the nonprofit side. But this really speaks to how our employees feel about community care, the work that we're doing, in partnership with Central Health, their commitment, and then how they feel they're being treated as employees. So we're very thankful that our staff took the time to answer the surveys, and it's done by a third party, and the recognition. While we don't mind accolades, but it's really not about the accolades. It's about the work that we're doing. But where this advantages us is by being able to represent to folks who are prospectively looking for an employer, is to indicate that we're a good employer, right? And that's possible through our relationship and partnership here with you guys at Central Health, through our shared enterprise, HR functions, our shared system functions as it relates to joint technology, economies of scale therein and thereof, right? Next slide, please. Happy to answer any questions that you might have, managers. Thank you so much for the opportunity this evening.
Thank you for the presentation. Appreciate it. I have a question, then I'll open it to the floor. You mentioned that you're in the process of renewing your Central Health as a co-applicant. You mentioned something earlier on the first slide.
I just mentioned that as Central Health's co-applicant, so the Health Center program, which is the federal grant that's received with all the benefits that come, inclusive of access to 340B pharmacy, purchasing power, Federal Tort Claims Act, all the doctors, clinicians, all the staff within community care is covered under the Federal Tort Claims Act, so we don't have to pay for professional liability. They're considered to be federal employees, as well as enhanced reimbursement through the Medicare and Medicaid services that we provide. That all comes to us through a federal grant authorized through Section 330 of the Public Health Services Act. That's the Health Center program. So community care in conjunction with Central Health. Central Health is the applicant, community care is the co-applicant, and together we receive the grant, and so collectively we're the grantee from the federal government's perspective.
Thank you for that. So
Yeah,
with
of
that,
course.
Meehan, I'm just trying to understand sometimes when, and I'm pretty sure others as well have, the relationship of Central Health and community care and what we have access, what we do not have access. I know, so in terms of your data, is this something that as your applicant, we can have easily access to your data, to your raw data, for instance? Is that something that we have access to?
I think it depends on which data. So the service data, patients, demographics, yes. Because Central Health now is in the direct provision of healthcare as a separate and distinct provider. We're two distinct entities. Then we have to defer to legal in terms of what happens with services that aren't being paid directly. We have multiple agreements with Central Health, one of which is a services agreement that pays for the indigent care services coming through and for medical access program patients, both MAP straight up and MAP basic. Sharing Medicaid data at a discrete level, we just need to talk with legal counsel in terms of what that looks like. But we've been pretty transparent with you as our peers here at Central Health.
So, as us now providing direct care, so our relationship has changed. I'm just like in terms of what, in terms of
hasn't
transparency, what information.
So a good
is
example
relayed
would
to
be
us.
is we would not, Manager Musaif would not be able to go ahead and share our contracts with a particular Medicaid MCO. So we can't, those are details as two separate providers, because then we have to, unless we're in a protected arrangement, which we are not right now. And so there are other arrangements that could be had where we could structure it. A good example is Community Care as part of a clinically integrated network that was formed last year with 49, well, we're one of them, so 48 other community health centers across the state to form a very large, it's the largest clinically integrated network. What that allows us to do in this network structure is to go ahead and do joint contract negotiations, arm's length. So we're not sharing what our contract looks like at Community Care. What I'll use Lone Star as an example because they're one of the participating health centers as well. We can't share our distinct Medicaid contracts with each other, but there could be de-identified information that's used to go ahead and negotiate a different agreement on the Medicaid MCO side, be that with United Healthcare, Molina, Amerigroup, which is now WellPoint, and or Superior, which is our largest insurer in the area. So there are some things that we just need to, as the relationships evolve, there's more direct provision of services. There's some things that can easily be shared, and then other things that just need to be tempered with legal advice.
Thank you.
Yeah, of
Appreciate it.
course.
I'm gonna open the floor. I know Manager Matwani had a question, and I can go.
Thanks, Chair. Thank you all for a really good presentation. I always love I think the density of data that y'all provide, as well as the analysis with it too, because one without the other is useless, right? I really actually, and having seen these presentations now for a bit, can appreciate sort of going from a lot of philosophy and of course numbers to really, really clean outputs with analysis to, I think we're turning the corner on outcomes, especially with just looking at on face those UDS metrics. I'm really bullish on what we have to see in the future. So thank you. And given that there's so much to chew on, I appreciate a couple of notions. First of all, the number of uninsured folks and that very large jump. Over half of folks are uninsured. Again, that was a jump of, I don't know, 7 points from last year, right? And so like just, I think that looks like something like 56,000 adults and 12,000 children. And it would be helpful to know how many of those individuals might qualify for ACA plans or not. I mean, just might qualify for ACA plans, might qualify for Medicaid potentially and just not have Medicaid. Do you have a sense of what that looks like, given the information that you already have on hand?
We do. So very thoughtful question, Manager Matwani. I think when we take a look at it, the vast majority of those individuals are not going to qualify on the ACA marketplace, the federal marketplace, as well as for Medicaid because they are undocumented individuals. We actually, and we're doing this again, but we did an analysis of Travis County residents based on what were in our records to take a look at who we would have thought otherwise would have qualified for MAP Basic. And it was a cohort over 18,000 individuals. We ran them through a third-party verification system. They have the ability through this third-party verification system to, A, go ahead and determine address. And so the vast majority, almost 67%, actually came back with a hit. Yes, they are a Travis County resident. What caught us off guard the most was about 9,000 folks had no other digital footprint other than their address. What does that say to us? These are folks who are cash only, mostly going to be undocumented individuals. So it was a very significant, large number. So for those folks, and so take it for what it is. This is a preliminary analysis. We're rerunning it now. It's more current because that's now almost 10 to 12 months old. So we're redoing it now. Happy to share that information with Dr. Lee, of course, and his team as we navigate this. They could go off market, right, if there was an insurance program that's available, but then they don't have the subsidy, so the cost is significantly higher if Central Health was to do something similar to what it does with the CHAP program, right? But they're not going to be eligible for Medicaid except for our prenatal patients, which are covered through the Children's Health Insurance Program, Parinate program, sorry.
I think you segued really well into what my next question was, which was around the efforts that you're making right now from texting, the lessons you're learning from that. The conversion rate is very low, albeit extremely important. Every single one of those conversions matters on was it CHIP or was it Medicaid?
It was Medicaid.
It was Medicaid.
Yeah.
As well as the phone calls, but again, low conversion. It would be helpful to know on the order of what number of thousands we're basically talking about thousands. And we're talking about a bottleneck in resources to be able to convert on those thousands. It seems to me that point of service, if it were feasible, would be the most efficacious way to route folks into their appropriate plan, whether it's an insurance plan that's ACA, whether it's an insurance plan that's off market, whether it's Medicaid, or whether it's making sure that the children have CHIP. Is that feasible? And if so, what kind of resources would you think would be necessary to do that?
I think it's feasible. Unfortunately, in Texas, there's a lot of obstacles to overcome on, for example, the Medicaid side. And so having someone who's available at the point of care or point of contact with that individual in real time is challenging.
Yeah.
And so we're doing a lot more virtually in that, as well as going ahead and doing online applications. But it's something where we need to build more robustness, to your point. One of the challenges is I'd like to see our sliding fee scale be able to be done at the point of care. Our Chief Operating Officer, Nancy Ban, is charged with doing that. Same thing with MAP Basic. There's a lot of documents that folks won't know to bring in necessarily, for which then there's the follow-up that has to happen. We try to inform and educate our patients beforehand, this is what you need to bring in, but there's a lot of follow-up. One of the significant changes that happened in the last year on the application process, for example, on MAP Basic, which we're very thankful for, was the requirement when there's a spouse to have a second signature on that application. That actually would delay the application for anyone that was on there. So that's been removed and expedites that. So we need to a certain extent, we need to get out of our own way on some of these applications as well.
Well, I mean, I guess my question is, what's the magic wand answer, though? I mean, clearly capacity needs to be built, but if you had the magic wand, what would it do so that we don't lose these folks? And I'm not just talking about MAP and Medicaid, but also, let's say,
presumptive
we were to
eligibility.
co-engineer a plan through the enterprise that might address some of the market disincentives or barriers that folks in poverty might.
So the direct answer would be presumptive eligibility. Other states do presumptive eligibility. I've been in other states as a CEO for a large health center where we were credentialed by the state based on our enrollment. As long as we hit a 98% accuracy, we maintained presumptive eligibility, which meant we collected the documents, we went ahead and brought that in. They were deemed automatically eligible. And at that point of care, they were enrolled. Now, the numbers didn't come across, but it would be retroactively applied to that claim based on that. So presumptive eligibility is something that I think really other states have done very well, which allows folks to more prospectively enroll in these benefits as opposed to trying to do all the legwork up front, which gets in the way of folks accessing care, right? When someone's sick, they need to be seen. And so we don't want the eligibility process to slow that down, so we go ahead and we actually still see them without that being,
Appreciate
Yeah.
that.
Thanks.
Yeah.
Sendero was the
Manager
subtext.
Motwani.
Sendero was the subtext there, so I'll let someone else ask
We,
about it.
Yep.
sorry, we're running out of time. Manager Valdez and then Manager.
I was gonna ask if you just wanted Shannon and go around.
Well, whoever wants to has a question, so I'm recognizing you because you raised your hand.
I thank you. Jason, if I'm not mistaken, you said that March 1st, there's gonna be a reinstatement of eligibility. Does that mean that the state's gonna go back to 3 months to make sure that the Medicaid costs get covered or cover those medical costs as they normally do with any Medicaid application?
Unfortunately, that's not the case for our postpartum women. So if they were gapped, my example was is if they lost coverage in October, they're going to be gapped. Say it was October 1st they lost, they're going to be gapped, no retroactivity back to October 1st through the end of March. What they are intending to do, based on Centers for Medicare and Medicaid Services approval, is that they will, as of March 1st, they're supposed to renew that coverage, which will take them from March 1st through September 30th of 2024 as my example. So they won't have achieved the full 12 months that they would have otherwise been entitled to had it been approved earlier, but they'll get a partial, and I think the math on that is they'll get 8 months or 7 months of coverage as opposed to the full 12 months. Anyone prospectively from March 1st forward will have 12 months if they deliver as of March.
Okay, and then in the demographic information with respect to the people that the members or the patients that y'all have seen, I know you said that you have about 68,000 new patients. Those were signed up into MAP or MAP Basic?
So the 68,203 is for the first quarter. So about 42% of those are going to be covered through MAP Basic. A lower number now on the Medicaid side, sitting about 32%. Medicare sitting at about 6-7%, and then commercial is about 12%, and then true self-pay sliding fee scale is the remainder, which is the part that's growing.
Okay, and in the numbers that you all have seen, are you breaking down the youth numbers so that we would know maybe it's 15, 16, 17, where they are, not 18 plus, so that we could see whether or not they're going into adulthood, the same thing on the back end where the seniors are, if we could see a trend.
Yes, Manager Valdez, we have that information. And to the question earlier, we can wholeheartedly share that with you guys, heat maps and stuff like that, and happy to do so. There's a lot of discussion within health centers across the country. What happens when someone turns 65, they now have a insurance card through Medicare, and everyone and their brother and sister are going after them in terms of, hey, you can come to our big shiny building, right? And so patients that have been with us for years end up transitioning. So we have to better understand how we retain those folks into our care, because we think we're an optimal place for that care to continue.
Thank you.
That's right,
Yeah.
call center.
So,
So is that?
Manager Valdez, are you done?
One last quick
Quickly, please.
comment to see whether or not Central Health eligibility is working with community care to see if there's any change in eligibility numbers that we as a board can look at to make in order to accommodate services for those that uninsured in Travis County.
We're happy to partner with
Well,
Dr. Lee and staff, however you guys would like, for sure.
I've already told Ann, but I'd like our chair to put that on as a discussion for an upcoming agenda.
Okay, thank you. And here we, Chair Kitchen.
I'll be quick. So to add to what Manager Valadez just mentioned, what would be helpful to know, and this would be something, Dr. Lee, for us to talk about as a board, what would be helpful to know is, in your experience, what obstacles you may have seen to enrollment in MAP and MAP Basic. In other words, you gave us one example, which was that second signature being taken off. I'd like to understand from a process standpoint, an administrative standpoint, what do you see that could be done to change our process that might be helpful? And we should also, Dr. Lee, understand that from our own staff, what they might recommend or what others might recommend. I wonder, for example, if online applications are truly 100% online, without having to have an in-person meeting?
Ours are, ma'am.
I don't know if MAP is. That would be one of the questions I would have. But
I would have to defer to John Morgan and his
we
team.
don't need to answer that right
Yeah.
now. But that's the kind of thing I would want to know. So so that we could consider, from our perspective, as close as we can get to presumptive eligibility for our MAP and MAP patients as possible. So if we could take that as a, okay, second question. This is a very quick one also. This is a yes or no. So I'm switching now to quality and outcomes. Do you all at this point in time, do you look at any of your outcome measures from an equity standpoint? And what I mean by that is, do you look at, like prenatal care compared to African Americans versus the white population or something like that? Do you do that for outcomes?
Yes.
Okay, I would love to see some reports around that.
Happy to share that as well. That's something we'll make sure that Dr. Lee gets to you and through his team, and happy to share that. We'll share 2022's data. 2023 is going to be vetted through HRSA, the Health Resources Service Administration, but we can share the preliminary data as well.
Okay, because I really appreciated this slide, but I'd love to have a little bit of more of a drill down for you guys to show us how we're doing, on how you guys are doing in terms of making progress on addressing disparities. So,
and the beautiful thing about the Uniform Data System report is much of this is actually available online as well.
Excellent.
And so we'll make sure that gets shared with Dr. Lee and team as well.
Okay,
Thank you. Dr. Lee and then Manager Jones. He had a question. Do you have? Yes.
Yeah, just quickly, you mentioned the 81% of those who are in Travis County and the 83%, I think, your number. Can you just quickly, my question is, can you tell us, are there trends going on of people leaving Travis County, moving into Bastrop and Caldwell County, and still participating in the program or receiving services?
There are some folks who've transitioned and displaced into other counties, but the majority of folks are prenatal and pediatric patients coming through, hence the 81.1% pediatric patients being Travis County residents versus the 84.4%, 84.5% for adults. We did do an analysis probably about a year ago or so, and we're re-upping this, wherein what we did is we looked at how the population below 200% has changed over the last 3 to 5 years. We saw a significant precipitous drop from 2021 or so. We saw 50,000 fewer individuals in Travis County below 200% of federal poverty. And then we looked at the surrounding counties, Caldwell, Bastrop, Hayes and Williamson, part of the metropolitan statistical area. And we thought, like many have hypothesized, that there was a net migration of folks out into these communities. The data analysis did not show that. What we saw was that there was a small gain in Hayes County as well as in Bastrop, but there was losses in small gain in Caldwell and Bastrop, a decrease in both Williamson and Hayes County. We then looked at San Antonio, Dallas, Houston to see if our trends were mirroring those. And what we saw was there was twice the reduction in those less than 200% without displacement compared to these other communities. So what does that mean? It means our community here as a whole has become more affluent, higher cost of living. Folks are starting now to actually have more livable wages. That's a very good, positive thing, but it doesn't translate into discretionary income to live off of when rent and other things are gone up. So we've had folks who are above 200% now, but functionally they don't make more than 200%, right, comparative to where they were short through years ago. We'll share that analysis with Dr. Lee as well, and he can share that with you. We're looking at those trends very closely. We've also analyzed what we refer to as vulnerable population footprints and how they've changed since 2010 to today in terms of how dynamic things are shifting in the community. And candidly, this is probably one of the fastest moving communities relative transitions like that than some of the experts have ever seen. Yes, sir. Thank you.
Dr.
Thank you, Chairman Satif. Jason, Tara, thank you for being here today. I just wanted to take a brief moment to recognize what an impressive quarter it's been, and what an outstanding FQC partner CUC is with us. Just want to mention a couple things. I think to win number one out of nonprofits for Best Place to Work is no small feat. And so many things go into that. Something else you said, Tara, actually, the fact that we have been able to overcome hesitancy for COVID vaccination, and that many of these patients are first-time recipients of COVID vaccination, there are likely a few people whose lives will be saved by that effort. And the many things that go into having the trust and the ability to reach out to the community doesn't go unnoticed. You made a comment, Jason, in the video about how the Black Men's Health Clinic strengthens the reputation of CUC, and my feeling is that CUC's reputation strengthens the reputation of the entire enterprise. So I want to say that on a personal note, Jason, I appreciate your welcome for me. It's so clear how deeply knowledgeable you are about not only the work at CUC, but the environment nationally. We have a great deal to learn together. I look forward to that. And I deeply believe we are strongest together in this shared mission, and I can't wait to do that journey with you. So, thank you both.
Thank you, appreciate that. Board members, any further questions? So I see none. Thank you all, appreciate it. See you next time. Thank you. And now I'm moving on to Sendero Health Plans. Sharon, Elvis, and Ellie will be presenting for Sendero. And members, I announce that the committee is convening in closed session to discuss Agenda Item 3 under Texas Government Code 551.085, Governing Board of Certain Providers of Healthcare Services. Thank you. 3, I'm still on 3. Yeah, so I asked them in the future. Sorry, it is why am I thinking of April? It is February 21st, 2024, and it is 5:43 p.m. Members, today we just we just left our closed session for item number 3. Do I have to state the time? So it is February 21st, 2024, and it is 6:04 p.m. And we just got out of closed session for item number 3, and there no further action on this item. With that, we'll move to item number 4, and agenda item number 4 is, receive an update and take appropriate action on contractual issues and the status of the Central Health third-party administrator for patient claims processing. And for this item, you will have Jeff Canoto, John Morgan, and Sharon Elvis will be presenting. John? And members, the presentation is with your packet.
Thank you for coming up, John. Thank you. This item is item number 4, and let's go to the next slide. We are requesting approval on this item. We're requesting approval to recommend to the Central Health Board of Managers the implementation of an internal claims system for both Central Health and Sendero in an amount not to exceed $1.2 million. Next slide. So what is it we're talking about? So we've had at least a briefing in a previous meeting related to our third-party claims administrator. So the system receives patient medical claims information from providers, from clinical providers and facilities that are used to pay for services that are performed on patients. Both Central Health and Sendero utilize the same third-party claims administrator. Unfortunately, both of us have received a termination notice. Central Health's termination is effective September 30th or October 1st, 2024, and Sendero's time period's a little bit longer, but their termination is through or is effective January 1 of 2025. It goes without saying that this system is critical for both organizations as it relates to performing data, getting data to utilize and to pay our providers and facilities for the services that they remit. Next slide. So the next part of this is, well, what's the plan? There really aren't a lot of options that are real viable. The best option that we have is to implement an internal claims administration function. And again, I think we've had some conversation about this, but just kind of walking through some of the elements of how we got here. The licensing of the claims administration would be through Sendero, through their existing HMO license. That's a part of the license. The plan is also to transition from the current third-party administrator software to the same application, which would also leverage some of the knowledge that Sendero has on their team related to existing or prior TPA implementations. And actually, I believe that experience relates to this particular third-party or this particular software. Some of the benefits, I know Central Health and Sendero have both had probably more TPA conversions than we would like to have. The benefits of having an internal run system are the long-term stability, cost savings that we would achieve over the course of processing claims, and then just the ability to not have multiple clients, but to have a focus on just Central Health and Sendero requirements as potential changes are made in any payment or claims structures that exist in the future. Next slide. So, of course, this is an option, a suggestion that has its risk, and one of the biggest risks is the short timeline related to the implementation period. Some of the tasks that need to be completed within this timeline is replicating what's called the claim system configuration. So at least on the initial implementation, we want it to perform and process claims in the same manner that it's currently doing, be able to replicate those results, have reliable results, and then just going through some of the system functions that you would ordinarily have in the implementation of a system, which would include testing and validating, looking at system cutover at the appropriate implementation period. I think one of the things that we'll have to work through is a claims run out. So we have certain dates where the system is terminated, the existing or the current system is terminated. And so how do we pay claims that services were performed prior to that termination? How do we direct providers and facilities to direct those claims to the appropriate location? And then last but not least are just any complexities that are either known or unknown. There are plenty of known complexities. During the course of implementation, there probably are a few unknown complexities that will come up also. And then just quickly, a couple of the mitigations. This system or this process has a lot of risk, but again, it's the same platform as our existing system, so we think that that's certainly a huge benefit. And then just relying on the TPA implementation experience of the Sendero staff. So they're, again, lots of experience in TPA implementation, so this isn't the first time that some of their leaders and the leaders of this implementation project would have gone through a TPA implementation like this. Next slide. So getting more around what the request is from a financial standpoint, what we're requesting this evening is that Central Health would fund the implementation costs. So these would be the total implementation costs for both entities with an estimated budget not to exceed $1.2 million, and parts of that budget related to, or a large part of that budget relates to, licensing of the application, the hosting of the application, staffing, consulting services. And then as we get a little bit further and learn all of the cost and the efforts related around both entities, we would work with Sendero over the next couple of years where they would pay for their implementation cost over that time period. We would probably just at some point figure out a way to amortize some of the cost related to Sendero's portion of implementation costs. So the proposal really is that Central Health would go in and fund the entire amount, and then we would figure out a repayment plan based on a computation or agreement of cost and how we would share those costs. So that concludes my presentation. I'll ask if there are any other comments that anyone has, or are there any questions that the committee may have?
Thank you, appreciate it. Can I have a motion on the floor?
Second.
Okay. Do I need to read it? I see.
Yeah, can you read it, please?
I move that the committee recommend that the Board of Managers approve funding in an amount not to exceed $1.2 million to implement an internal claims administration system for Central Health and Sendero.
I second the motion.
Thank you. So we have a motion on the floor and a second. Members, any discussion? Manager Martin?
Thank you. It's to be amortized by Sendero partially. I was wondering, would an equation be based perhaps on number of claims filed? If Central Health is using 70% of the system for claims, would that be the calculation based to some extent?
Yeah, I'm not sure at this point. We have different types of claims, different volumes, and so I think we'll need to assess the level of effort that's common, the level of effort that it takes on the Central Health side, and the level that it takes on Sendera. So that might be a part of the allocation basis. I'm not sure. I think there's still some discussion that we need to have just related around what's fair and equitable for both entities. Go, Ronnie.
There are multiple ways to calculate these kinds of arrangements. Sometimes you do it on a per member, per month basis. Sometimes you do it as cost plus. Sometimes you do it on the volume of actual claims process. So we're looking at all of that to try and determine. But the reality is that the claims that Central Health has and that are being paid now by Curative are not as complex as some of the claims that Sendero has. And we have a whole lot more regulations and timelines that we have to meet that don't necessarily apply. So some of the complexity is built into that. But as Jeff alluded, I've mentioned I've recently hired a chief strategy officer, Karen Ader. She has owned and operated her own TPA for like 15 years, so she understands the industry really, really well. And she also has recently worked with Curative, not the Curative administrators, but as Curative, the client of Curative administrators, because she was working on the health plan, and Curative administrators were paying claims for her. So she's very familiar with the inner workings of VBA. I too, when I read Vista 360 Health, we use VBA software. So we have, and several other people, we have recently hired, Dr. Jennings has hired a nurse as our director of UR and quality. She also is very familiar with VBA. So we have a lot of people who know this system. On top of that, our whole team have been using this system all along. And so we're taking it out of their system, putting it into a cloud model. And we've already received the first download of data from Curative to begin looking at it and begin massaging it to see how consistent it is. So we are intent to deliver by the deadline that Central Health needs to meet, which is the September 30th. We're hoping to be operational, by September 1st, if not sooner, to make it work.
So out of curiosity and perhaps retrospective view, why did they elect to cancel these contracts?
Curative is growing. They have a health plan, and that was my previous job, was putting that health plan together as market president. And they now are growing that plan so much that they want to focus exclusively on the development of that plan and didn't want to continue to support other clients that they felt drew from their energy to focus on their own book of business.
So they're not just canceling our contracts, they're exiting the TPA business.
Okay, thank you.
Thank you. Manager Matwani?
What does Central Health pay now for TPA services?
What do you pay for TPA services?
Does Central Health have a cost?
It's approximately $1 million a year.
Thank you.
So, got it, thanks.
About $1 million too, I think.
So eventually it'll be a cost saving for us.
But we pay 2.4. So, it's costly.
So in terms of efficiency, I guess, it's more efficient. So, okay.
Yeah,
I'm sorry.
yes,
I didn't understand your
I would just say, generally speaking, while I'll let Manager Mochwani cover her. Yeah, we would expect long-term, absent implementation costs, we would expect to see substantial savings for both entities as we.
Thank you. Any further questions? So I see, yes, Dr. Ling.
Sorry, I would just build on the point. Not only do I expect this to be financially efficient, but there's also a level of interdependence and trust that we build together as Central Health relies on Sendero for the TPA function. And that proves to be a strong part of our foundation. So I'm excited to see us working together in this fashion, and that's a nice bonus that will save about $2.4 million potentially.
Thank you, appreciate that. So we have a motion on the floor and a second. No further discussion. All in favor?
Aye.
So it moves unanimously. Thank you. Now, moving on, members, finally to item number 5, confirm the next Budget and Finance Committee meeting date, time, and location. Managers, our next Central Health Budget and Finance Committee is tentatively scheduled for Wednesday, March 27, 2024 at 4 p.m. at the Central Health Headquarters, 1111 East Cesar Chavez, Austin, Texas 78702. At this time, I'm ready to accept a motion for adjournment. Manager Matwani adjourns. A second. Manager Valdez. We are adjourned. Thank you.
Okay, thank you, managers. I'm going to move us right into executive committee. I'm aiming to have us out of here by 8 o'clock. We'll see how quickly we can go through executive committee and look at maybe a break between that and the Board of Managers meeting. So, good afternoon. Today is February 21st, 2024, and it is 6:20. As a quorum of the committee is in attendance, I'd like to call to order the meeting of the Central Health Executive Committee. We'll now proceed to the Executive Committee agenda. The first item, may I have a motion to approve the minutes of the Central Health Executive Committee, January 24th, 2024? A motion from Manager Brinson, a second from Manager Musaitif. All in favor? Aye. Okay, the minutes are approved. Item number 2. Review and provide direction to staff on the prioritization and tentative scheduling of items for consideration at future Central Health Board and committee meetings. So, Brianna Yanes will be presenting for us.
Okay, I will go through the March agenda items, starting with strategic planning on March 6th. We will have our minutes. We will form the communications, community outreach, and engagement subcommittee. And we have several updates under integral care items. And then we'll have homeless related items, including bridge, street, mobile, and respite. And then we will do an update to the annual strategic priorities and budget timeline. And then lastly, we'll do an enrollment and utilization dashboard update, which will just be informational, no presentation. On that same day, we'll also have the communications, community outreach, and engagement subcommittee meet. And then on March 27th, we'll have the Budget and Finance Committee, where we'll have minutes, financials. I believe those will be January. And then also we will discuss the update to the annual strategic priorities and budget timeline. And I made some updates to the one that's in your packet, so the printed version isn't the same. And then the process of CEO financial contract authorization for executive committee, we'll just have our standing tentative schedule item, and then Board of Managers meeting, minutes, investments, and then we'll have a discussion on recommendations to increase access to public meetings, and then a performance review update and lawsuit updates as standing items for now.
Okay, thank you. And so the update that you made, managers, from what was in your packet perhaps, was that the item update to annual strategic priorities and budget timeline is going to be on March 27th under the Budget and Finance Committee. It's also on March 6th under the Strategic Planning Committee. It's under both those committees because it impacts both of them. And that's an item that will give us all the opportunity to talk about our budget timeline and our opportunities as managers to engage in that process a bit earlier. So again, the goal being that we're not in a position where we're having to engage in that process later at the last minute. So, okay. Any comments or questions? I'll start on this side of the room. Manager Jones, Manager Musaitis, Manager Okay, go ahead.
I think you've mentioned it. You're going to add an agenda how to engage
Yes.
community.
Yes.
Okay, that's it. Thank you.
Yes, and that'll be on the board managers meeting. Okay.
No questions. Just consideration for adding. Consideration for putting a future agenda item together for Central Health Board to discuss MAP and MAP basic
Yes.
eligibility.
Yes,
And if we needed a retreat to make sure that everybody on the board understood what that process is, how it works, and why it's so important, that we at this time look at that, at changing maybe the eligibility
Okay.
criteria.
Thank you for mentioning that. The first item you mentioned with regard to eligibility is something that we have mentioned, and I know that the staff is looking at, that should be on this update to annual strategic priorities. It should be on that timeline, so we'll see what a meeting will have that. Your suggestion about a retreat, I think, is an interesting suggestion. I would ask Dr. Lee, as well as the staff, to consider that. If anyone else has any comments they want to make on that right now, I think it could be very useful for us.
That would also include, I would hope, the equity issue.
Yes, because it would allow us a more concentrated time to talk about a number of items, equity being one of them, perhaps MAP eligibility being one of them. So thank you for mentioning that. I'll ask the staff to explore that for us.
Could we add just to that agenda item?
Yes, yeah, can I come back around to you? Okay, Manager Martin, do you have anything? I do not. Okay, all right, Manager Jones?
No, I would encourage a retreat.
Okay.
That would also incorporate, where we see ourselves in terms of strategically working with our partners or our system, and make sure that we're all on the same page, understanding what that is. So I would incorporate that in a retreat as well.
Okay. Manager.
I'm sorry, go ahead.
No.
Okay, yeah, on the note of the retreat, I definitely appreciate the retreat and that it comprised the notions that we've already discussed. However, if it were to be a lofty thing to plan a retreat and get everyone together, something that takes 3 to 6 months possibly or not, then I might also suggest, if possible, that we at least do an in-service or something on the eligibility thing, because I would
Yeah, we don't want to wait on that.
Yeah. Thank you.
Yeah, so I think that's a point well taken, that we want to get to the question about the eligibility sooner rather than later. And so I'll just look to Dr. Lee and the staff to see what they recommend in terms of the retreat as opposed to when we take that up. Manager Musaitis?
Yeah, I think this was discussed at a prior meeting. Community care and our relationships, I would like that for us to discuss it further.
Okay. I think that that comes under what Manager Jones was suggesting in terms of our partnerships, right? Yeah, so we'd include the community care in that. Okay? Any other? All right, I'm not seeing any other comments. Let's see. There's no motion necessary for this one. Thank you. All right, item number 3, confirm the next regular executive committee meeting date, time, and location. Managers, our next Central Health Executive Committee meeting is tentatively scheduled for Wednesday, March 27th at 4 p.m. or immediately after the Budget and Finance Committee meeting at our offices here at Cesar Chavez. At this time, I'm ready to accept a motion for adjournment. Manager Musaitis so moves. Manager Brinson seconds it. All in favor? Aye. Okay. All right. We're adjourned. Now, managers, it's 6:30. Are you all wanting a 5-minute break, or are you ready to go forward? We're going to go forward unless I hear...
3-minute break.
Okay. Let's take a 5-minute break. If you haven't eaten, I think there may be food in there, but do come back in 5 minutes, because it's going to take us about an hour and 15 minutes or so for our next... So... Um, we're going to go ahead and get started, everybody. So, okay. Managers, I'm calling the Board of Managers meeting back from its recess at 6:33. The first item of business will be the consent agenda. We have 3 items on the consent agenda. The first one being approving the minutes of the 2 committees that are listed there. The second one being the receiving the quarterly investment report and ratifying Central Health investments for January 2024. And the third item being approving the appropriate action on contractual issues related to the third-party administrator, which we discussed and that was recommended by the Budget and Finance Committee. So may I have a motion to approve the consent? Motion from Manager Valadez.
I move that we approve the consent items C1, 2, and 3.
Thank you. Do you have a second? Second from Manager Motwani. Any discussion? All in favor? Aye. Okay.
I'm sorry, Madam Chair.
Yes?
The only thing I wanted to say is they took away our original motion sheet, and what we got back was just Budget and Finance Committee motions. I don't have any others.
Okay. Okay.
Oh, well, thank you.
Okay.
Oh, I can wing it.
All right, we'll move on now to we'll now proceed to the regular agenda. The first item on the regular agenda is to announce the planned formation of and appointments to the Communications, Community Outreach, and Engagement Subcommittee of the Strategic Planning Committee. And that's an item for Manager Brinson. Do you want to?
Okay, I move that we.
It's not necessary to move. Okay. It's just an announcement if you want to announce that.
Yes, so we are forming a new committee under the Strategic Planning Committee I beg your pardon? Oh, sorry.
That's okay.
Yes, we are forming a new subcommittee under the Strategic Planning Committee, and our goal will be to just watch the city over time to see where populations are moving to and away from, just paying more attention to trying to make sure we're equitable in where we're focusing our resources over time.
Thank you. And did you mention who's going to chair that?
I'm chairing that, yes.
Okay, great. All right, thank you. Item, what?
Can I make a comment on?
Yes, go right.
Okay, as I said in our meeting today, I just want to emphasize as we do this, we don't want to do it at the expense of targeted intervention efforts that we have in certain areas in terms of outreach, in terms of community engagement that are ongoing. So I just want to emphasize that and note that for the record. So.
Okay. Okay. We'll move on to item number 2. Receive an update and take appropriate action to approve an interlocal agreement with the City of Austin regarding a partnership with the City of Austin Central Health and Integral Care to collaborate on addressing homelessness. I believe we're going to take this. Let's see, Monica Crowley and Perla Cavazos will be presenting. I think we're going to take this into executive session. So I announce that the board is convening in closed session to discuss agenda item number 2 under Texas Government Code section 551.071, consultation with attorney. So if we could go into closed session. All right, today is February 21st, and the time is 7 o'clock, and we are entering open session. Managers, we're taking up item number 3, discuss updates on matters related to a performance review contracted by Travis County, including delegations to the president and CEO to execute necessary agreements between Central Health and Travis County and Mazars USA. So Monica Crowley will be presenting.
Monica Crowley.
Jeff Canova.
So this is a fairly brief update on the performance review with Mazars Inc. Central Health has completed its submission of documents to Mazars, and we are entering the phase of the engagement where Mazars is going to be conducting interviews with subject matter experts, with staff. They're going to be reaching out to different community members and potential potential stakeholders. We've already completed an interview of our community engagement and outreach and external affairs group, and the finance team and the external audit firm, and then we're scheduling other interviews as quickly as our schedule allows us to.
Do we have a timeline at the moment about when this review will be completed? Do we know, or?
I don't know about some of the, I don't know if they're on schedule according to their interviews, but I think it had a timeline of around June.
Okay.
To do some of the initial reporting.
So as far as we know, we're still talking about June.
As far as I know, we are.
Okay. I'm going to start on this side of the room. Any comments, Manager Jones, Manager Montgomery, Manager Misaka? Any comments? Any comments, Manager Valadez? Okay. All right. Thank you very much. Okay, we will now go on to item number 4. Discuss and take appropriate action to authorize the president and CEO to negotiate and execute a contract with Sheets and Crossfield for legal services not to exceed $450,000. Stephanie McDonald will be presenting.
Chair Kitchen, I do not need to present. This is,
Pardon?
I do not need to present.
Okay.
What I am hoping is that you will take action.
Okay.
And delegate the authority to the president and CEO to negotiate and execute a contract not to exceed $450,000. This is specific to our eminent domain relocation efforts with TxDOT, and believe that this continuity will be very helpful to us.
Okay. Can we get a motion and then we'll see if there's any...
I apologize.
okay.
We may need to take a 5-minute recess.
Oh, okay.
That's what we've been working on all this time, and while the motion sheets were taken away, we've been writing this thing since we started. So if you would give us 5 minutes,
Okay,
we'll be right
take a
back with you.
5-minute break.
Thank you.
Ready? Okay. Okay, managers, we're back to item number 4, which was discuss and take appropriate action to authorize the president and CEO to negotiate and execute a contract with Sheets and Crossfield for legal services not to exceed $450,000. So may I have a motion? Okay, Manager Valadez, you want to read the motion?
In red,
Yes.
I move that the county attorney authorize, not authorize, it's not past tense, the use of outside legal counsel in this matter, and that the board determines that if additional counsel is advisable, and that working on ongoing cooperation with attorneys from the Travis County Attorney's Office, the president and CEO is authorized to negotiate and execute a contract with Sheets and Crossfield for legal services not to exceed $450,000 on terms that are the same or better as presented by staff.
And Madam Chair, before you take your motion, I just need to make a statement if that's okay?
Okay.
Okay.
Before we take the motion?
Before you take your
Okay,
motion.
go ahead. Mhm.
What was that, David? Okay, well, is it okay if I? Okay, thank you.
What, could I take the
Okay.
second and then have you speak?
That is fine.
Second? Okay. Manager Brinson seconds. Okay, go ahead, Ms. Brown. Go ahead.
Thank you.
Mhm.
It is important that I note that for this particular motion, that there is going to be a meeting in the future between the parties at Central Health and the Travis County Attorney's Office, because there is a difference of understanding as far as Chapter 281 is concerned and representation of Central Health.
Okay.
So I needed to make that known to everyone that we will be meeting soon in regards to that, so that everybody will be on the same page and have the same understanding.
Okay. Yes, did you want to say something?
Chair Kitchen, I just want to point out that this is a bigger conversation than just the specific item.
Yeah.
Okay, thanks.
Yeah. I do have one question about this specific item. Because I'm not sure if I'm tracking it right. So are we saying that, are we approving going ahead with the, with this outside counsel? Okay. We're not saying that we need the county attorney's approval first. No, we're not. Okay, all right. That's probably the subject of the conversation that you're talking about.
That is going to
Okay,
be the subject
but
of
with
the conversation.
Yeah, but with this motion, the board is authorizing going ahead and continuing, and going ahead and executing this. Okay, all right. Let's see, I'll start over here. Any questions? Any questions, Manager Martin? No? Go ahead.
I'm not sure if I can ask this question here or not, but we've authorized legal in the past, so what has changed with this matter?
I think that's beyond this matter. But it is a good question that we probably need to have a conversation
So
about.
this is not the first time we're authorizing for legal services.
No, it isn't, and this is the first time I've seen it this way.
Thank you.
Okay. All right. Manager Jones?
I just have a similar concern raised by Manager Masaita. So are we basically authorizing this in order to do services that Travis County would normally do?
So if I can, these are services that Travis County started. There's been a change in some of the attorneys, and to have continuity for this particular project, the Travis County attorney actually said that it was okay and we can move forward with the board actually hiring one of the attorneys that had already worked on this
Oh, I see.
particular project.
Okay.
And so we will be working in tandem with each other on this particular matter. Not a
Okay.
problem.
Okay. Okay. I don't see any further comments or questions. All in favor? Aye. All right, it passes. Okay, we'll move on to item number 5, which is confirm the next regular board meeting, date, time, and location. Managers, our next Central Health Board of Managers meeting is tentatively scheduled for Wednesday, March 27th, no.
Yes, March.
Yeah, I'm sorry. For Wednesday, March 27th at 4 p.m. at Central Health Administrative Offices. At this time, I'm ready to accept a motion for adjournment from Manager Valadez, seconded by Manager Musaitif. All in favor? Okay. Thanks, everybody. We are done.